Good afternoon, everybody, and thank you for joining us today for this interview with the chief investigators of the basilar artery Chinese endovascular trial, presented today at the plenary session at the European Stroke Organisation Conference in Lyon 2022. I'm Professor Alastair Webb. I'm an associate professor at the Wolfson Centre for Prevention of Stroke and Dementia in Oxford, and I'm joined today by Professor Zhenmin Ji from the Zhuangwu Hospital of Capital Medical University in Beijing, and Professor Tudor Jovin from the Cooper Neurological Institute in Camden, New Jersey, in the USA, the chief investigators of this study. So to kick off, Professor Ji, could you tell us what's the principal question that your study aimed to answer?
The aim of the study was to assess the safety and efficacy of thrombectomy for stroke due to basilar artery occlusion in patients within 6 to 24 hours from symptom onset or time lasting well.
And why did you think that this trial was necessary at this particular time?
We believe that this trial is necessary for the following 4 reasons. First, the clinical outcomes of basilar artery occlusion are among the worst in all types of ischemic stroke, carrying an exceptionally high morbidity and mortality rate. Second, although endovascular thrombectomy improves clinical outcomes, in patients with large vessel occlusion in the anterior circulation, level 1 evidence in support of endovascular treatment for patients with acute basilar artery occlusion is lacking. Third, there was no any randomized trial examining the best treatment for acute basilar artery occlusion in the 6 to 24 hours time window. Finally, clinical data suggests that reperfusion of the basilar artery is associated with improved clinical outcomes. Therefore, we highly expect a positive outcome with this trial.
Excellent. And I'm very impressed to have done such an impressive study. Congratulations to both of you. So would you be happy to tell us what are the main findings of the study?
We found that for all stroke patients due to acute basilar artery occlusion, thrombectomy in the 6 to 24 hour time window could significantly improve the 90-day functional outcomes as compared with the best medical treatment controls. I want to say that this is a randomized trial conducted at the highest standard. I want to sincerely thank my dear collaborator, Tudor Jovin, for working together on this technically difficult trial. I also thank all my colleagues who works on this trial for their tireless effort in the last 7 years to reach this milestone. Thank you so much.
Excellent. Thank you very much, Professor Ji. And it is very impressive, the benefit that has been demonstrated. And there are a couple of questions about the design of the study that I thought would be helpful to discuss. And Professor Jovin, I know that the presentation today is about the results of an interim analysis of the study, which was pre-specified, rather than the entire population. Why are you presenting an interim analysis now rather than waiting to the end of the study? Has a stopping point been reached particularly?
Well, we are actually going to present the entire, the final analysis that includes all patients. The bulk of this analysis includes the patients enrolled up to the interim analysis, because largely of difficulties with enrollment during the pandemic and also equipoise issues after the interim analysis, after the number of patients that reached the required pre-planned number of patients for the interim analysis, we were only able to enroll a handful of additional patients. The interim analysis includes 212 patients. That was pre-planned, and there were an additional 5 patients enrolled since the interim analysis until the data safety monitoring board, until all the entire data was collected, database closed, etc. And there were 5 additional patients enrolled. And the study was stopped at the recommendation of the DSMB because pre-specified stopping boundaries in favor of thrombectomy were crossed.
Excellent. Okay, that makes a lot of sense. And so this is the entire population. That's good.
It's the entire population.
Great. The other question I did was raised in the methodology paper before this presentation today. I noticed that the primary outcome for the study was changed from an MOS of 0 to 4 to an MOS of 0 to 3. And I was wondering why the primary outcome had been changed and what the reason for that was.
Yeah, and thank you for asking this question. This is a critical point. When we planned the trial, which was around 2015, the data, randomized data on basilar artery occlusion treatment was scarce, and we had to make assumptions that were not necessarily based upon conducted randomized data. We chose the ranking score 0.4 as a cutoff because based on utility weighted analysis, we thought that this is the cleanest differentiation, if you want, in terms of patients' quality of life perception, 5 to 6 meaning being 0 and everything else being sort of, if you want, life worth living. But after around the time of our interim analysis, a lot more data had come in, especially the BEST and BASICS trials. And we realized by looking at the treatment effects that our assumptions of treatment effect were to the T fulfilled with a cutoff of 0.3 and less so with a cutoff of 0.4. And in addition, all the other previous randomized trials, BEST and BASICS, have used 0.3 as their cutoff. And we thought it makes sense to also align our results with what has been published previously. I just want to emphasize and make it clear that obviously this change was made before any kind of data unblinding took place.
And you raised a very interesting point about the recent publications of BEST and BASICS, which were done in the kind of classic time window for basilar thrombectomy. Both of those studies demonstrated less convincing benefits of intervention compared to the results found in your study. What do you think the reasons are for the differences we find between BEST and BASICS in the normal time window, or the early time window, and BAOCHE in the later time window?
Yeah, so a great question. And I would say that let's take BASICS first. I think with BASICS, the fundamental difference is the use of intravenous TPA, in my opinion. Also, the fact that in our study, most of the patients, a much higher proportion, had an NIH stroke scale score on admission, a baseline NIH stroke scale score of 10 or greater, which in BASICS has been shown to yield statistically significant benefit in the subgroup analysis. And in fact, in BASICS' original study design, that was the admission NIH stroke scale score that rendered patient eligible for the study. And in addition to that, patients received intravenous TPA, which I think clearly works in basilar artery occlusion. So that diluted a bit the treatment effect. So the BASICS did show a difference between the two arms. That difference was not statistically significant. I would say the treatment effect was less robust than what we have found. So that's BASICS. With regards to BEST, we know that formally BEST was a negative trial, and that was because of a very high number of crossovers. If you actually look at the as treated or even the per protocol population, our results are actually remarkably similar with those of BEST. We had emphasized from the before BEST was published or presented in our investigators meetings, the critical importance of making sure patients are not there are no crossovers, I think that got us to the fact that there were so few crossovers got us to the kind of results that mirrors those of BEST in the per protocol or as treated population.
Okay, excellent. And so if you look at the data from all the 3 trials in the whole, do you think at the moment there's sufficient evidence to justify thrombectomy as our preferred intervention for basilar artery occlusion? And do you think that applies just to your time window or to the entire time window from onset?
Another excellent question. I certainly do think that for the 6 to 24-hour time window, and with the selection criteria that we chose in BAOCHE, I think thrombectomy is justified. At the time of this recording, we don't know what the results of another basilar occlusion trial are that is going to be presented 2 days before the BAOCHE presentation. I think that will answer a lot of your questions. But I would say that certainly for basilar artery occlusion patients presenting with an NIH stroke scale score of 10 or greater, which constituted the vast majority of our patient population in our study, along with the data from BASICS. I think for those patients, to me, it's pretty clear that these patients should be treated with thrombectomy. The rest, I think we'll find out more from attention and also from meta-analysis, which I think is going to be very helpful in this circumstance.
Excellent. So thank you very much. And that's our time for today. So congratulations again to both of you and to all your team for a very impressive study and a kind of truly impactful result for our practice and the literature.
Thank you, Professor Webb.